Hey everyone, this is Ryan here, and welcome to our next series on pharmacology. So it's a notoriously challenging topic that appears on the Part 2 dental boards, but the good news is it has the least amount of questions of all the sections at only 31 questions. So if you're finding me for the first time, a special welcome to you. And for all of you who have been with me since the beginning, thank you so much for your ongoing support. I really do appreciate it. And so I actually just upgraded to a professional microphone, so hopefully the audio quality only goes up from here. So that being said, like all of my past videos, I'm going to be focusing on only the highest yield topics, the only things you should know for the dental board exam. And while I'm gearing these videos for exam prep, they are also designed to give you overview of these topics for clinical application and general knowledge. So as you can see, we're going to start talking about local anesthetics. This will likely be a two-part video, and it'll be a part of the 3 A's of dental pharmacology, that is anesthetics, antibiotics, and analgesics. And these are probably the 3 most important topics I want to cover, and so we're going to start with local anesthetics today. So we're going to talk about amides versus esters, the 2 main categories of local anesthetics. We're going to talk about their pharmacodynamics and pharmacokinetics. We're going to talk about calculating local anesthetics, which if you can do it for one problem and you know how to do it, you can solve any problem that involves calculating local anesthetics. And this will probably leak into the second part of this video, and we'll talk about a brief overview of different injections. So here are our main 2 categories. We have the amides, which are metabolized in the liver, and we have esters that are metabolized by this enzyme called pseudocholinesterase in the blood plasma. So these 2 categories are extremely important to remember and to distinguish from each other. So amides liver, esters plasma. And here we have a comprehensive list for the exam purposes of the amides and the ester local anesthetics. So we have lidocaine, bupivacaine, mepivacaine, articaine, and prilocaine as part of the amide category, and we have procaine, cocaine, tetracaine, and benzocaine as part of the ester category. And so you might notice that they all end in this suffix caine here, which is a really important suffix to remember. If you see that, you know you're dealing with a local anesthetic. Now, because this is a comprehensive list, at least for exam purposes, you only have to memorize one column because then you know what the other column is. So I memorize the esters because there are less of them. It's a little bit easier to remember. And procaine and cocaine, they have this sort of internal rhyme going on, so that can kind of link those 2 together. And tetra is a prefix meaning 4, so I remember that there are 4 esters I have to remember. And then benzo just kind of maybe matches this pro-co-benzo, tetra, something like that. If you can remember those 4, then you know if you're dealing with something like prilocaine, that's not one of the 4 I remembered, so it has to be an amide. One of the important things I wanted to mention was that esters are less commonly used because they're actually a bit more toxic than the amides, and they're more allergic. There's a higher rate of allergic reactions. And it's due to the presence of this methylparaben, which is a food preservative, also antifungal, which can cross-react with esters. So, amides and esters. So let's go through each commercially available local anesthetic one at a time and talk about one high-yield fact per local anesthetic. So just 1 or maybe 2 facts to know for each of these local anesthetics. So the first one is lidocaine, and the commercial name is xylocaine. And important to know here, for the board exam, they're only going to be talking about them with relation to the chemical name, which is a much more important name to remember. If they do include the commercial name, it would be like I have listed here, like in parentheses after the chemical name. So lidocaine is the safest anesthetic to use in children, which they could ask you that question directly, and so that's an important fact to remember. Bupivacaine, also known as Marcaine, is the exact opposite. It's not safe to use in children. Next we have mepivacaine, which is also known as carbocaine or polocaine, and this one causes the least amount of vasodilation. So local anesthetics by themselves are actually vasodilators, but they're often packaged with epinephrine, which is a vasoconstrictor, and we're going to talk more about that later. We also have articaine, known as septicaine, which has one ester chain. And you may be thinking, well, that doesn't make much sense because we talked about amides and esters. So why is articaine in the amide category? Well, articaine is mostly an amide. It has mostly amide characteristics, but it has this one little ester chain. So why is this important? Well, the board exam could ask you which of these local anesthetics is metabolized in both the liver and the blood plasma. And because articaine has both amide and this little ester characteristic, it's metabolized technically in both sites. So that's important to know. Then we have prilocaine, also known as cetonest, and it's linked to this condition called methemoglobinemia. And this is a blood disorder in which an abnormal amount of methemoglobin is produced. This leads to too little oxygen delivered to the tissues and can be induced by any local anesthetic, but particularly prilocaine. And so if you get a question, it's going to link these two things. Also important to know is that bupivacaine is the longest duration, has the longest duration of all the local anesthetics here, whereas articaine has the shortest duration of all these local anesthetics. And I'll give you one more fact to take home, and that is the percentages that are attached to each of these local anesthetics. So they're packaged in carpules at standardized percents. And this is going to come into play when we talk about calculating local anesthetics. But I want to plant this seed right now while we have all the names up. So lidocaine comes packaged in 2% solution, whereas bupivacaine comes packaged at 0.5%, so 0.5%. And the reason is because it's such a strong chemical that it can only be packaged in a low percent, hence why it's not safe to use in children, and it's a long-lasting chemical. Mepivacaine is the only one here that is packaged in two different concentrations at 2% and 3%. It's also the only local anesthetic that can, well, I shouldn't say that, but it's one of the few local anesthetics that can be packaged without a vasoconstrictor because it causes the least amount of vasodilation. Then articaine comes in 4%. And we'll leave it with those four, the most important four local anesthetics that are used in dentistry today. All right, and esters, there's less info here because esters are much less often used due to them being generally more toxic and more allergic, like we talked about before. So we have procaine, we have cocaine, which is the only exception I talked about local anesthetics by themselves being vasodilators. Cocaine is actually a vasoconstrictor. So that's the exception. Then we have tetracaine, and last but not least, we have benzocaine, which is still commonly used as a topical jelly prior to the local anesthetic injection. Okay, now we have this topic of pharmacodynamics, and this is basically referring to what the drug does to the body. So what kind of effect does the drug have on the person receiving that local anesthetic? So it's easy to get overwhelmed by the nitty-gritty details about drug mechanisms, but I'm going to keep this nice and simple. Local anesthetics are sodium channel blockers. That's the most important thing to remember. And this sodium channel is in the membrane of a neuron. So this is a membrane of a neuron. And the pain signals to be transduced requires depolarization from influx of sodium through these exact channels. So the easiest thing to do for a sodium channel blocker would just be to block this receptor from the outside. But unfortunately, it doesn't work that way, and it's not quite that easy. So these channels can only be blocked from the inside. So now, the drug has the job of penetrating this neuron membrane to reach the inside and then block it from within. So, up here in the top left corner of this image, it shows that the drug has a charged or ionized form, and then also an uncharged or non-ionized form. And as it shows here, only the non-ionized or uncharged form of the drug can diffuse through this hydrophobic interior of the neuron membrane and get through to this side. And this is critical. Why exactly? Well, inflamed tissue has a lower than normal pH, or it's an acidic environment, which decreases the amount of non-ionized form available because the presence of these excess protons here in an acidic environment favors equilibrium to the ionized form, which again means there's less of this non-ionized form that can diffuse through the membrane and actually block the sodium channel from within. Thus, the lesson to take away is that local anesthetics are much less effective in inflamed and infected tissue. And so that's basically what this bullet point is summing up there. And there's this concept of critical length, which I didn't get tested on when I took the board exam, but it's basically saying complete anesthesia occurs when 3 consecutive nodes of Ranvier are blocked, and there's a better chance of anesthesia the more length of the nerve is bathed in anesthetic, which makes sense because that just means more of these sodium channels are blocked, favoring a discontinuation of pain transduction. All right, and next we have the other side of the coin, which is pharmacokinetics. And whereas pharmacodynamics was talking about what the drug does to the body, pharmacokinetics is what the body does to the drug. In other words, how it processes it. So we have a couple of key facts here that I want to hone in on for the board exam. So we have this idea of blood flow, and if we have increased blood flow to the site of injection, we have a shorter duration of action of the local anesthetic. And this makes sense because increased blood flow would carry the drug away faster from the site. If we have increased lipid solubility, also called hydrophobicity, that means that the local anesthetic would be primarily more potent and secondarily have a longer duration of action. And this is because of that concept we were talking about diffusing through the membrane, because more drug can diffuse through the hydrophobic interior of the membrane if it's lipid soluble, and then bind to the receptor. So an increased protein binding is a longer duration of action because this means that the drug has a greater attraction to the receptor sites. And remember, receptors are mostly protein. So that also kind of makes sense, that these lipid-soluble protein binding both lead to a longer duration of action. And lastly, we have this tricky concept of pKa, and the only thing to remember with pKa is that the lower the pKa is, that means the stronger the acid is. And this is important because it will give up its proton faster, and if we go back to this mechanism, if it's going to give up its proton, that means it will be in the non-ionized form, which means it would diffuse through the membrane faster, have a faster onset of action. And I didn't get tested on these specifically, but I do think they are important. So unfortunately, sorry guys, I have some numbers for you to memorize, specific pKa's for these amide local anesthetics that we've covered. All right, so now I've kind of hyped this up a bit, calculating local anesthetic. And I have a way that will really help you calculate local anesthetic concentrations quickly, efficiently, and with little to no confusion. So we're going to break this down really simply, and I promise that this will all link together. So 1 milliliter of liquid at sea level weighs 1 gram. This is just kind of like the classic science fact to remember. And why is this important? Well, a carpule, or a cartridge of anesthetic, which I have pictured down here, contains 1.8 milliliters of liquid. So the entirety of the liquid in the carpule weighs how much? Well, if we have 1 milliliter of liquid weighing 1 gram, then we have 1.8 milliliters of liquid weighing 1.8 grams, or 1800 milligrams. So this is helpful, but it's not very relevant clinically because we want to know how much of the actual local anesthetic drug is in this carpule. We don't really care about the entire liquid because there's a lot in there. There's the vasoconstrictor, there's preservative, liquid vehicle like saline, and distilled water. So there's a whole bunch of components, but we only want to know how much the little bit of local anesthetic weighs. So how do we figure that out? Well, for 100% solution, let's say hypothetically this entire carpule is all just this lidocaine, and it's 100% lidocaine, then we can say it would weigh that 1.8 grams that we just talked about, or 1800 milligrams. But remember those percents I was talking about before? This is where they come into play. So say we have 1% of local anesthetic. Well, all we have to do is divide this number by 100, because we got 100% divided by 100 to 1%, so we can do 1800 milligrams divided by 100 to get 18 milligrams. And so the gist here, the secret to all of this calculation is starting with this 18 milligram block and building from there, just like Lego blocks. Always start with 18 milligrams and then multiply this by whatever number percent your specific anesthetic is. So here's an example. For 2% lidocaine, you have 36 milligrams per carpule, because now we had 1% was an 18 milligram block. Now we just add two of those together for a 2% solution. 18 plus 18, we get 36. How about for 4%? We multiply 18 by 4 and we get 72 milligrams per carpule. And that's the gist of it. That's all you have to do. So say you have 2 carpules of this 4% articaine, all you have to do is multiply this 72 by 2 to get 144 milligrams. And that's the gist. That's all you have to remember for calculating local anesthetics. So pretty cool. All right, so here's a practice question. It's a little tricky. A carpule of 2% lidocaine solution with 1 to 100,000 epinephrine would contain how much epinephrine in milligrams? Well, wait a minute. We didn't talk about epinephrine. But you have all the tools you need to solve this problem, I promise. So let's start with our block of 18 milligrams. And what do we do with our Lego blocks of 18 milligrams? We multiply them by the number in the percent. But this time, it's not asking about the anesthetic, it's asking about the epinephrine, which isn't in the form of a percent. It's in this really convoluted ratio of 1 to 100,000 parts, but we can convert it to a percent. In other words, 1 to 100 would be 1%, 1 in 100. So 1 in 100,000 would be 1/1000th of a percent. Or you can think of it this way, 1% divided by 1,000 with these 3 zeros. So if 1% is our 18 milligram Lego block, all we have to do is divide that 18 milligram block by 1,000. So we would move the decimal over 3 places to the left. So for 1/1000th percent of epinephrine, we get 0.018. And we just moved that decimal place 3 places over to the left from 18 to get 0.018 milligrams. And this is tricky, but the more you practice with it, the easier it will become. And hopefully this practice question helped with that. So we were just talking about epinephrine, and I mentioned before it was a vasoconstrictor, and it has 3 purposes as a vasoconstrictor in local anesthetics, and these are crucial to remember. So it prolongs numbness, and as I talked about before about blood flow, increased blood flow means a shorter duration of the drug. So a decreased blood flow would be a longer duration of anesthesia. And because vasoconstrictors constrict blood vessels, they decrease the blood flow to the area, and thus less local anesthetic is carried away from the site, leaving more locally to act on those nerves and those sodium channels of the nerve membranes. The second thing it does is reduce toxicity. Again, because it's constricting the blood vessels, that means there's less blood flow. Again, less opportunity for the local anesthetic to enter the bloodstream and to have less systemic impact. The last thing it does is promote hemostasis, and it's again the same concept. It's for the same reasons because it's constricting blood vessels and reducing blood flow. And one cool thing to remember is that the epinephrine, or whatever the vasoconstrictor is counteracting the vasodilating properties of the local anesthetic. So on balance, you're going to have vasoconstriction. All right, and lastly, we talked about a ton in this video, but I'm just going to leave you with some numbers to commit to memory. So I apologize in advance, but these are important numbers to remember. So for the maximum amount of epinephrine for an ASA1 patient, which means a systemically healthy patient, that would be 0.2 milligrams of epinephrine. And now that we've talked about calculating epinephrine, you could figure out, say, how many carpules that would be for 2% lidocaine with 1 to 100,000 epinephrine. That would be a cool practice problem to work out. And then max epinephrine for a cardiac patient, that's a patient with some cardiac condition, say an arrhythmia or a recent myocardial infarct, that would be 0.04 milligrams, so much less epinephrine allowed for that case. For maximum amount of lidocaine without vasoconstrictor, that would be 4.4 milligrams per kilogram. And then if it's lidocaine with vasoconstrictor, that would be 7 milligrams per kilogram. Why is more allowed with the vasoconstrictor? Because of the reason we just talked about. It reduces toxicity by reducing blood flow to the area. Alright guys, that's it for this video. I know we covered a lot, so feel free to rewatch and pause as needed. I hope you found this video helpful. If you did, please leave a like and subscribe to my channel if you haven't already for more on local anesthetics, pharmacology, and all things dentistry. Thanks so much for watching guys, and I'll see you all in the next video.